On behalf of the Environmental Change and Security Program, I'd like to welcome you to the Woodrow Wilson Center. My name is Sean Peoples, and I'm a program associate at the Environmental Change and Security Program. And I want to thank you all for joining us today for this program, Coffee and Contraception, Combining Agribusiness and Community Health Projects in Rwanda. Before I introduce today's speakers, I want to give you a little rundown of where you're sitting here today, the Woodrow Wilson Center. It's the living memorial for our nation's 28th president and the only president to achieve a PhD. And so it was created by an act of Congress in 1968. The center strives to link the world of ideas and scholarship to the world of policy. And the center's Environmental Change and Security Program facilitates dialogue on issues such as environment, health, population, security, and broader development issues. Late last year, I had the great fortune of sitting next to our two speakers here. In Ethiopia, we had some very long, bumpy, tight car drives. So I'm very happy to be on some solid ground, no bumps, with Irene Kitzantides and Jason Bremner. Irene recently returned from Rwanda Sunday, I believe, and she worked as the PhD advisor with the USAID Global Health Fellowship Program at the Sustaining Partnerships to Enhance Rural Enterprise and Agribusiness Development Project, or the SPREAD project, in Butare, Rwanda. And in a moment, she'll share her experiences and lessons learned from working on the ground at this USAID-sponsored Integrated Population Health and Environment Project. By the way, a lot of these insights are going to be available as part of ECSP's Focus newsletter series, and that will be available, I think, in the next month and a half. So please look out for that, both online and in a physical format. After Irene presents, we have Jason Bremner, the Program Director for Population Health and Environment at the Population Reference Bureau. And he's going to serve as today's discussant, giving us a little bit of a broader picture, context of these PHE programs, and also give us perspective due to his close work with the East Africa PHE Network. And I think that's going to leave ample time for discussion today. So we are live webcasting. When we are in the discussion period, please allow some time for my colleagues that will be passing around the mics. We want the folks at home to be able to also participate. And just one more technical note, the PowerPoints and all of the links that we have that we'll be discussing today are available on the web page for the listeners at home or at their offices. So if you are watching in the webcast, please do know that you can also participate and see the PowerPoints and whatnot. So Irene, I'd like to turn the floor over to you. Thank you so much for agreeing to come speak.
Okay, thank you. Can everybody hear me okay? Okay, so I'm here to talk about the USAID SPREAD project. It's a unique PHE approach, population health and environment. I'm not going to go into too much what PHE means. I think Jason's going to talk a little bit about it, and I'm assuming many of you know a little bit about this approach, and if not, we could field questions. But basically, it's an integrated approach to development that cross sectors to promote synergy across disciplines and more holistically meet community needs. So the SPREAD project, I'm actually going to start by giving you a bit of a context first for those of you that may not know much about Rwanda and Rwandan coffee, and I'll give you a little bit of a background of the PHE challenges and a little bit of the background on SPREAD. And then I'm going to talk specifically about the integrated health and coffee interventions and the accomplishments that we've had and the challenges over the last couple of years, and then share some lessons learned, and then we can have some time for questions. So for those of you that don't know, Rwanda is it's a tiny landlocked country in East Central Africa, and it's bordered by Uganda to the north, DRC, Congo to the west, Burundi to the south, and Tanzania to the east. It's about the size of Maryland. It's very small, but with twice the population. It's estimated at over 10 million today. And it's the highest population density in Africa. There's about 356 people per square kilometer, so it's very, very densely populated. Rwanda is known as the land of 1,000 hills. This is a photo taken from where the majority of our coffee and health activities have taken place. This is in the southern province. I believe it's Huye district. Rwanda is primarily an agrarian-based society where about 90% of the population relies on these hills for food and for their livelihoods. As you can see, almost every inch is cultivated, and the average land size per farmer is about 0.8 hectares per farmer, per family, and about a quarter of the population lives on 0.2 hectares per household, which is far less than what's required to meet their nutritional needs. Population pressures and diminishing land holdings due to high fertility rates, war and genocide and subsequent migration have caused a rapid decrease in forested and protected areas and increased soil infertility and food insecurity. And close to 57% of the population lives under the poverty line. Here's just some data and statistics about population health and environment issues. There's still a high fertility rate, about 5.5 children per woman. The growth rate is at 2.8%, and at this current rate, the population is projected to reach over 14 million by 2025. Again, there's this problem of diminishing land holdings with each passing generation, with large family sizes and small plots of land. Poor soils as a result of overcultivation, cultivating on steep hillsides, and problems with erosion. Again, poverty and food insecurity. HIV/AIDS, it's about 3% prevalence nationally, which is quite low relative to the region, but it rises to 7% in urban areas. And condom use is quite low, and there's other factors such as gender issues, gender-based violence, alcohol, which could exacerbate, and rapid urbanization, which could escalate the epidemic. The unmet need for family planning is around 36%, and infant mortality and maternal mortality are still quite high. And common to many developing countries, there's severe water and sanitation access issues in many areas. It varies where you go, but as well as high rates of diarrheal disease, respiratory infections, preventable diseases, and malaria is also common in certain areas. And then post-war and genocide, there's many effects. Since 1959, this country has been going through conflict, which culminated in the Civil War in the early 1990s and genocide in '94. There's over 1 million orphans. There's high rates of depression and post-traumatic stress disorder. So these are things just to keep in mind, the context. But it's important to note that despite all these challenges, there's hope in Rwanda. The country's made remarkable progress over the last 16 years. They've become sort of a development success story, especially in terms of reproductive health. Just from 2005 to 2007, contraceptive prevalence rates went up from 10% to 27%, which is unprecedented. The total fertility rate went from 6.1 to 5.5 in just these 2 years. And again, gains in infant mortality and under 5 mortality. This can greatly be attributed to the strong government leadership. The government really sees family planning as a cross-cutting tool to fight poverty, to develop families in their country. So it's definitely, that's been key to the success. It's also one of the safest countries in Africa, despite some recent problems. Up until this year, it was still called the safest country in Africa. Tourism is on the rise. People come visit the mountain gorillas and other natural areas. Corruption is relatively low, and lots of foreign investment. As a result, it's got one of the highest economic growth rates in the region. So it's really been a remarkable recovery. And just to tell you a bit about Rwandan coffee, since that's the context, Rwanda boasts almost ideal growing conditions for the Arabica variety of coffee, which is used to produce the finer specialty grade coffees. It's been a leading export since the early 1900s when it was introduced, and it's been a major source of rural revenue since then. USAID has been the principal provider of technical assistance since 2000. Projects such as Pearl and the ADAR project, ACD Avoca, there was about, I think, over $12 million invested. And it's really been instrumental in putting Rwanda on the map for specialty coffee. And for those of you that know coffee, it's become a highly sought-after specialty coffee origin. These projects built close to 40 washing stations, creating thousands of jobs. And exports for fully washed specialty grade coffee went from 0 to 8 million in 7 years. And as a result, over 20,000 farming families doubled their incomes, and in 2005 and to date, over 50,000 have benefited from the gains in specialty coffee. So the SPREAD project, as Sean said, stands for Sustaining Partnerships to Enhance Rural Enterprise and Agribusiness Development. And SPREAD is a follow-on from the Pearl 1 and Pearl 2 projects, also funded by USAID from 2000 to 2006. SPREAD is a 5-year cooperative agreement between Texas A&M University and USAID from 2006 to 2011. So we're coming on to the final year and a half of implementation. The funding is a total of $6 million from USAID, $5 million for economic growth, and $1 million for health over the 5 years. The health funding is primarily PEPFAR for HIV/AIDS prevention, then family planning, population, followed by maternal and child health funds. There's been additional funding from private investors and primarily those involved in the UK and US specialty coffee sector, as well as the Global Development Alliance, public-private partnership between USAID and private companies to develop bird's eye chili pepper, as well as pyrethrum, which is a flower found in Rwanda that's used to make insecticide, natural insecticide. So the goal of SPREAD was to continue to expand or build on the successes of Pearl in specialty coffee, as well as expand to pyrethrum and bird's eye chili pepper later in the project, and as well as integrate this community health program. Coffee is still the main activity for SPREAD, so I'm just going to tell you a bit about the primary coffee activities. SPREAD aims for value chain management every step of the way from seed to cup to improve quality. There's programs for research, coffee quality, co-op development, organic agricultural practices, trying to promote better agricultural production, and capacity building happens at all levels: the farmer level, the cooperative level, the National Coffee Board. And the health program focuses primarily on those two levels, the farmer and the cooperative level. So the rationale for integrating this community health program and the assumptions upon which the program was based was first that coffee revenue could be spent on family health needs given appropriate access to health information and services. Seeing as these farmers had seen increases in their incomes, they could feasibly spend more money on things like commodities such as condoms or water purification solution, or the mutuelle, the community-based health insurance. Secondly, integrating health outreach into coffee and co-op activities could enable rapid access to an otherwise underserved rural income-generating population. And thirdly, integration would lead to programmatic synergy across health and agribusiness programs. Just realizing that farmers, when they're unhealthy, are not able to put in the work involved to produce a high-quality coffee or to become involved and engaged in their cooperative activities to have a strong cooperative. And in general, having these health services was thought to help fulfill the overall SPREAD goal of improving lives and livelihoods. The target areas of the health program in the southern province for coffee, we've intervened in 2 districts, Huye and Nyamagabe, since October 2008, 2 cooperatives and 1 private female-owned enterprise, totaling over 10,000 farmers, but we're also, reaching their families and their neighbors during these community outreach interventions. And in the northern and western provinces, we just started expansion to pyrethrum and scaled up to work with 5 pyrethrum farming cooperatives around the Volcanoes National Park. And that's pyrethrum there on the bottom. So the approach SPREAD uses to integrate its activities is we really try to build on the existing assets of the cooperative. The existing management and extension structure of meeting farmers where they are with both coffee and health services. We also really try to complement local and national public health policy and partners. For example, rather than recreating our own curricula, we used Ministry of Health curricula and their own IEC materials and brochures and reprinted them, as well as materials for peer education from PSI and FHI. As these have already been validated, there's no point in recreating the wheel. So to get into the activities now, we've trained and mentored over 300, I think it's close to 400 now, animateurs de café, so coffee extension agents. And these guys were already in the cooperative as employees, extending information on better farming practices, how to, and other cooperative issues. So we approached them and asked them if they would be willing to also be health extension agents, and they were very willing. So we've trained them to also extend health information, as well as peer educators, both youth and adults, for behavior change communication. Again, realizing, I guess I should say that our mandate from USAID was to do more of a community health approach, because there were several partners in country already supporting clinics, doing the clinical support. So we were tasked with trying to change those behaviors, such as increasing uptake of available health services. There are services available in these rural areas, but people often weren't going, whether they didn't know about them, or it was a little bit far, or there was stigma around getting, asking for condoms or family planning. There's many myths around family planning and the side effects. A lot of stigma around HIV and, as I said, condom use. And so we were asked to sort of, graft these kind of behavior change communication messages into the work with the coffee farmers. So that's what these guys are doing. So on the bottom there, we have some youth being trained on how to do condom demonstrations. And then there's a coffee extension agent on the right doing an extension, both coffee and health meeting in the hills. So they do both coffee and health at the same time. The adult peer educators and coffee extension agents also refer to health services. They have little slips that they give to clients to go to the health center where they get it stamped and bring it back. So we also know not only how many people were referred, but how many people actually received the services at the health centers. They're also selling Sur Eau and Prudence. These are the socially marketed PSI, Population Services International, has these socially marketed health commodities available in Rwanda. So Sur Eau is for water purification, and Prudence are condoms. So these were also extended through the coffee washing stations, sold there during coffee season, as well as sold via these extension agents in their communities. We also focused on mobile clinics, bringing services to the farmers during harvest time, trying to choose locations that were convenient to their either coffee sales or processing activities at the washing stations or other areas, working with the cooperatives and the local health centers. This is also a strategy the government uses to reach people. They have special campaigns, so we're actually supporting the government to get out there, and we facilitate health centers to go out and do the actual HIV testing, family planning, treatment of intestinal parasites during the 3 months of coffee harvest. There's also a radio program, Imbereheza, which means bright future, and it's primarily a coffee talk show that's promoted and supported by the Coffee Lifeline program, and they've agreed to integrate 5 to 10 minutes of health at the end of each program. So this photo down here is a group of youth waiting to be tested outside near a coffee washing station during the mobile clinics. And on the right is a local lab technician from a health center nearby who's doing the rapid testing analysis in these mobile clinics. And lastly, we try to leverage the strengths of local partners, knowing that we have a small health program. We don't have all of these resources and equipment. So we've looked around and seen what's out there. And the Health Unlimited, for example, they're experts in community theater for health advocacy. So we brought them in to help train some farmer groups because they really love community theater and they always ask for it. And so this photo right here is a competition that took place in the Nyaruguru district last year. And it's discussing, there's a man holding a bottle of wine and yelling at his wife, and it's discussing the issues around coffee, using coffee money for alcohol, and the conflict that it can bring into the household. There's films, PSI has films that we try to use and their guides with our peer educators. We try to engage local partners like the Planned Parenthood Federation and PSI to help with follow-up for sustainability so that they have contact with these farmers and could maybe continue with them after spread is finished. We support district health plans for their activities, such as family planning clubs, their own mobile services, trying to be flexible outside of our work plan to also support local districts and their needs. And also some hygiene and first aid activities to help fulfill fair trade requirements for our cooperatives that are fair trade certified. This woman here on the right is using a kanakla. It's a water-saving, portable hand-washing mechanism that's set up at the coffee washing station. So over the last couple of years, these are some of our monitoring data that I just wanted to share with you to give you an idea of some of the scope. So far, over 120,000 people were reached with HIV/AIDS prevention messages. Close to 90,000 were reached with family planning and reproductive health messages. Close to 40,000 for MCH messages, maternal and child health. And, close to 4,000 people were tested for HIV during these mobile services. 248,000 liters of drinking water were purified. This is calculated by the number of bottles of Zero water purification that was sold via the cooperatives. And close to 1,500 condoms were sold via the cooperative structures. 347 women are new family planning users. There could maybe be more, but this is what we actually track in terms of the referrals and the mobile services. And over 1,000 people were referred for VCT, family planning, antenatal care, and received care at local health centers. And it's also quite cost effective. Just a basic cost breakdown with our budget over the last year and a half and the number of people that were reached. Just with HIV/AIDS prevention education alone cost less than $2 a person. So this is some qualitative data that came from a midterm evaluation that we just did. And just to take a look at people's perceptions of the program over the last year and a half. And I won't read them all, but one female beneficiary says family planning has been very important because it has allowed us to put some of our money into savings. And then a spread agribusiness manager, because somebody who had worked in the Pearl Project only doing agribusiness before said, we used to talk about growing coffee, making money, buying material things like bikes, not about problems like malaria, HIV/AIDS, etc. Someone could have 5 million Rwandan francs in the house, but could suffer from malaria where medicine costs 500 francs due to ignorance. You have to teach people about production. You have to also think of their health to improve their lives. And then one cooperative manager says, the big lesson I learned is that you cannot achieve your coffee production objectives at 100% without addressing the health of the farmers. And a district official says that the fact that spread uses a community health approach enables us to work with populations who were previously difficult to reach. And the last quote has to do with the reduction in emergency loans that have happened as a result of decreased family conflict, potentially as a result of the behavior change communication around gender and sharing money management responsibility within the household. And these problems would trickle down to the cooperative as well, who people go to for emergency loans and conflict resolution. So some of the challenges that we've had, just the community barriers in general, as I said, around gender, alcohol, reproductive health. Men are often barriers to reproductive health and starting family planning and using condoms because they often will leave these education sessions to be for women only, and they won't necessarily participate. But I have to say that coffee has been a bit of a better entry point to reach these men, because they are interested in the coffee work because it's income generating. And so we've had some peer educators say, yeah, I'll often start off a meeting and talk about health and then go into coffee so that we know that people will stay and listen. So we're fairly confident that the message is getting out to some of these men, but the barriers are still there. Also around savings, people need better capacity to learn how to manage their money and save. Just increasing incomes alone is not enough. And also they request, income generating activities outside of coffee because that's only once a year. And again, those gender relations, choosing when to start family planning, how to spend family revenue, those have been issues. Another challenge is the short life of the program. We sort of got a slow start The health program was a bit of an add-on because the agribusiness staff who were managing the project in the beginning didn't really have much health expertise, any actually. And there was supposed to be a subcontract with PSI that never materialized, and so it took a couple of years to get the program really off the ground. So now that it's happening and going well, it's difficult because there's only a year and a half left, and it may not be enough time to build the capacity required for sustainability. And there's a very high remaining need, especially in the pyrethrum areas. Those areas around the Volcanoes National Park are extremely difficult to access. Health knowledge is very low. Even access to drinking water and sanitation is extremely difficult because of the volcanic rock. You can't dig. So that's a big challenge up there with the pyrethrum farmers. Integration has been challenging to really use the best of all programs to work together and collaborate because it wasn't very well articulated in the beginning in the program design plans. As I said, health was a bit of an add-on. And the distance between coordinators, we have offices in Kigali, in Butare, and Musanze. These are each about 2 hours apart. So it makes consistent collaboration challenging. And again, just the general resource constraints, small staff, small budgets to really focus on this. Monitoring and evaluation has been challenging. There was no baseline health data, and we were sort of in a rush to get the program off the ground. So there's no baseline health data or integrated indicators. And communication with all partners could be strengthened. We have a lot of reporting requirements at the district and national level, both U.S. government and government of Rwanda, and sometimes those lower level, sector level authorities and local NGOs. The communication, reporting to sharing information has been a bit challenging. U.S. government restrictions have also been tricky. With the vertical programming of economic growth and health, it's difficult to actually integrate in the field, and there's extremely high volumes of reporting that have to go. They're very specific across PEPFAR economic growth. We have separate indicators, reporting mechanisms, different activity managers. So really working together and trying to collaborate across programs is difficult. And also sometimes funding restrictions. The specific line item of maternal and child health funding that Spread received, we weren't able to do any infrastructure developments around the Volcanoes National Park. We were allowed to educate on how to teach people to wash their hands and drink clean water, but they had no water to access. So that's tough, I think. Sustainability, there's, again, the imminent project closure. That's an issue for sustainability, and the low financial and technical capacity of cooperatives and partners. There's a will to continue the activities, but really the nuts and bolts of covering transportation, logistics, coordination costs, keeping people refreshed and trained, and also motivated to do the work is going to be challenging. And there's been ideas for an exit strategy, but it needs to be finalized over the next year and a half of the program so that appropriate capacity can be built before the end of the project. So some of the lessons that I've learned through this process is that farming families do need more than simply increased incomes to improve their lives and livelihoods. Simply giving them more money in their pockets is not enough. There needs to be a whole range of life skills for savings and for planning and for resolving some of these gender issues, and thinking about family size and just the whole picture is important. And I think I think communities realize that. Stakeholders have realized that. And although communities may not be deemed high risk, say for HIV prevention funds, generally we try to target commercial sex workers or truck drivers or those that are the drivers of the epidemic. However, there is a high unmet need in these rural areas, and as evidenced by the low knowledge, the amazing community response, and the uptake of services, there is a need there. And it is indeed feasible and cost-effective and worthwhile for agribusinesses to combine health outreach and cooperative or agribusiness activities. And managers also realize that it actually doesn't cost all that much, and that the benefits can be huge and can support the business. Although we don't have real data on the synergy, I think it's felt. I think the perception, the perceived benefit is there. And the community-based peer farmer approach is very useful. It's a valuable way to reach farmers with regular health information and behavior change communication. Community members, beneficiaries, all stakeholders really appreciated this approach, thinking that the message is better heard when it comes from your neighbor, somebody who understands your reality rather than an outside. Sometimes even community health workers are seen to be a little bit of a different status than the farmers themselves. So that was a good approach, the peer education. Strong support and mentoring and supervision of peer farmers are crucial to ensure their quality and consistency of their messages. I think that's one strength that Spread really has worked on, is to meet with them monthly to do refresher trainings, troubleshoot. They give reports. There's just sort of this constant close mentoring and supervision. Staff go out into the field and supervise them, sort of do surprise visits and see how they're doing, just so they feel supported, and also so you can check and see how the quality of the message is going and how the community is responding. So that's been key. And also community engagement and alignment with government of Rwanda and U.S. government priorities ensures complementary rather than duplicating service delivery. There's been some concern that maybe Spread is duplicating services because there are community health workers already working. But it's clear that if you, and it came up in the evaluation as well, that because the planning happens together, you can sort of divide and conquer. It's not something that is a complete parallel program, but working with the local authorities, you can sort of collaborate on outreach activities so that you're not reaching the same people twice. You can sort of fill gaps, but it's crucial to spend time doing that community engagement and consistent planning and coordination together. So that's it. If anybody has questions, thank you for your time.
Thank you, Irene. And we're going to hand it over to Jason.
Thanks, Sean. And I'd like to congratulate you on your first chairing of a session here at the Wilson Center. So, I'd like to thank the Environmental Change and Security Program for hosting Irene, who has been in Rwanda for 2 years now and hasn't had a chance to share information about this great project with those of us here in Washington, other than those who've actually gotten out in there. And I understand you've promised to do a future focus piece with the Wilson Center on the Spread project, so I want to thank the Wilson Center in advance for doing that. And those are great pieces. I think some of them are probably outside, and they do highlight these projects. I was asked to come to put this one project into context and to really talk regionally about population health and environment efforts. And I'll do that really just through three main messages, and they're related to why this type of effort, what is it, and I think Irene has actually answered quite well what we're talking about, and where else are these efforts underway. And starting with the why. Well, how many of you saw the Jon Stewart show recently? And let's just say that despite recent reports in popular media, falling fertility is not happening by itself. It's not. Efforts have been underway for decades. Hundreds of millions of dollars are being spent to meet the needs of women and couples in terms of their family size and their contraceptive needs. And so fertility is not falling by itself. Sub-Saharan African current fertility, I guess I'm from Population Reference Bureau, so I'd better bring some data along. Sub-Saharan African total fertility rate right now is around 5.3. That's an average, and that certainly masks that rural rates are quite a bit higher than that. And looking at a few countries in sub-Saharan Africa, data from the most recent DHS. You mentioned that Rwanda's total fertility rate is 5.5, in rural areas a little higher, 5.7. But in other countries like Uganda, you have rural rates of 7, Zambia 7.5, the DRC 7, and so the and contraceptive prevalence rates in these rural areas are extremely low. 3% in the DRC, 15% in Tanzania, 15% in Uganda. So while we've made great strides in getting information out to people and commodities out to people, we've largely reached the low-hanging fruit. And we've largely met those who are easily accessible. And the needs in rural and even rural remote areas, as you mentioned, remain a great challenge. And not just for family planning or HIV prevention, but really for health services as a whole. And so I think that a big answer to the why is that our work remains far from finished. I'd just like to highlight, bringing to one more number, and I want to thank Mara, my trusty policy analyst, for bringing this to me right at the last minute here. Anybody have a guess as to what the assumed total fertility rate for sub-Saharan Africa will be in 2050 under the medium UN population projections? Guess? I'll take any guess. 4. 4 would get us to 8.7 billion. What would it be? Well, this is their assumption. Their assumption under the medium projection. Too high. It's already at 7. 2.46. 2.46. We are now at 2010. We are at 5.3. We have a long way to go in meeting unmet need, and especially in rural, remote areas. So that's the why. What? Well, I think I want to have one more idea behind the why, and this is just to highlight what Irene mentioned around the Volcanoes National Park. I think in 2000, an analysis was done on population in biodiversity hotspots by Richard Sincata and Robert Engelman. And recently a colleague, John Williams, has been working to update that publication, and he recently shared some of those results with me. And he said that since 2000, he found that since 2000, population in the Conservation International biodiversity hotspots, those places that are most important and threatened areas of biodiversity, those areas have grown by 187 million people since 2000, and there are now 1.45 billion people living in the world's most important and threatened areas of biodiversity. So in those places where people depend greatly upon natural resources, they also don't have access to the health services that they need to meet their livelihood needs, as Irene mentioned. So this is a challenge. What? Well, new innovative efforts are needed. This project is an example of health interventions being integrated into non-traditional sectors. And I think Irene mentioned the challenges required: new partnerships, creative financing, new capacities. And so these are the challenges of meeting health needs in rural areas, going beyond what the health sector itself can do and finding new ways of reaching underserved remote populations. And so I want to thank Irene for her effort, because I think it's been innovative in getting, I think that when Irene got there, there wasn't a clear way of how to meet the health needs of these farmer cooperatives, and I think that she worked quite hard to explore and innovate. So congratulations. There are several efforts underway like this one. It doesn't stand alone. And I think that there are creative financing mechanisms being used to do this. I think USAID, this particular project, is an interesting example of missions, different programs working together. They called this Heather, you can correct me if I'm wrong, but a health wraparound, where the EGAT unit already had an existing project, and infrastructure out there. And they said, well, what if we add a small health component to a population that we aren't meeting under our existing bilateral efforts? And so I think I want to congratulate the mission with some prodding from the office here in Washington with coming up with an innovative way of doing that. And this isn't the only place that I see some kudos going on back and forth there to some of the responsible parties. But this isn't the only place where this creative health wraparound is being experimented with. I think we've seen Tanzania. There's a project in Tanzania along the coast. There is a new project in Mozambique. This is one of 2 projects in Rwanda that are using this mechanism. But there are also private foundations and other development partners that are seeking new ways to do this. And then there are also partners, some of whom who are here today, who are helping to share and promote the best practices learned from projects like SPREAD. The Balanced Project is a cooperative agreement that's seeking to get those best practices out to organizations that are interested in doing this innovative, integrated type of work. And I encourage you to contact Linda Bruce in the back about the Balanced Project if you're interested in learning about these best practices and how they're getting those out to interested implementers. And finally, where? I think I've said that this project is just one of a larger set of integrated efforts. And at PRB, let me move over here, we're trying to, well, let's just say that I'm constantly called by people who want to know where these projects are happening. And that there is no central list of these projects, but I'm not a travel agent. I'm not a good one at least. So I'm trying to create a map that captures these projects or this set of projects. And let me just say that this is by no means a complete inventory of all these interesting integrated efforts. We've done quite a bit of outreach to try to get people who are doing these types of projects to send us information. If you are here today and you have not been in contact with PRB about an interesting similar type of project like this, contact me and Maura Graff. Maura, would you raise your hand, please, about getting your project onto this map. But this is a new map. This is a Google map that you can play around with. I'm just going to open this and demonstrate to you that you can go to this map, or you will soon be able to go to this map and see a body of, right now, about 40 projects. The different implementers, you can see that WWF has been doing quite a few of these. Conservation International, DSW, a whole host of local organizations that you don't know the name of, but are doing very interesting things. And if I zoom in here, this is just using Google Maps. If you were to look for directions around Washington, it's the same mechanism here, but you can also see satellite view. But getting closer, you can see that a lot of these projects are around national park areas, are meeting need in remote areas. There are some around in the DRC. So these are efforts to get out to some of the most remote areas. That said, my belief is that your understanding of these projects is only as good as the dirt on your shoes. And I proudly look down at my Washington work shoes and see a fine ring of red dirt. And I encourage you to take this map, look at where projects are, and the next time that you're in the field, visit one of these projects, see it with your own eyes, talk to people, and get some dirt on your shoes and see what's going on. I think I just want to leave it at that, and welcome any questions about the broader set of projects that are going around East Africa.
Okay, thank you very much. We're going to open the floor to questions right now, and please, if you could, give us your name and affiliation, and wait for the microphones so that we can have this discussion for the folks at home too. Okay, over here.
Thank you very much. My name is Julia Clonis. I'm an economist, independent consultant, practitioner in development, working with international organizations. My focus is on gender. You mention it repeatedly as an obstacle. I wonder whether your efforts, to what extent has it helped or changed the gender dynamics that your project has more or less brought about? Empower women, inter-family dynamics, and so on. Thank you.
Thanks. We in this qualitative evaluation, there was many references to the impact on gender relations in households. It's hard to really tell the impact. It's all self-reported. But several people across male, female beneficiaries, cooperative management, they all said that, or several people said that there's been changes in men being able to relinquish the sole decision-making responsibility for money management within the household. There have been some changes, speaking with their wives, trying to make decisions about family planning together, trying to make decisions about how to spend revenue together, rather than men taking all the decisions themselves. One woman actually said that through this project she's become, she's one of the peer educators, she's become able to speak to her children about reproductive health without shame. And she's also been able to negotiate sex with her husband, because often in Rwanda it's a bit of a forced affair, and men decide. It's not a consensual relationship. And so I think people are starting, I think at least the efforts have started to raise awareness around these issues. So whether men are really, in fact, believing that, at least they're saying that in a way that they know that it's a positive thing to talk with your wife about how to spend money, and how, whether it's actually happening in the household, it's difficult to determine. But the dialogue is out there. And I think with youth also it's changing a bit. We've had some community debates about, who should make decisions about family planning. Should it be the man or should it be the woman? Or, and people go to one side of the room if they agree with one aspect. And we saw youth kind of creating a new segment in the room and saying it shouldn't be the man or the woman. It should be the couple that decides. So I think there's some changes occurring. I think there's a long way to go. And it's taken a little while to uncover this, and in the beginning we were just doing basic ABC HIV prevention messages, and then as you get to know the community and you realize there are these other cross-cutting issues that will impact basic ABC and prevention and uptake of family planning. And so I think it's a process, and I think that's something that that managers realize we should work on more, and they're starting to have those discussions about alcohol and so.
And we can collect 2.
Good afternoon, ladies and gentlemen. My name is Rosemary Secara. I'm the president of Segeros International Group. Our main business is coffee, tea, and cocoa from Kenya, especially. I'm initially from Kenya. We're trying to promote African resources and telling people about Africa and how Africans can use their resources to help themselves into empowering women and young people, because Africa is a very rich country all over the world, but people don't understand what is in Africa. So I'm going from every head of state of Africa, locally and internationally, to talk about the positive of Africa using their resources. And we have an organization called Hope for Tomorrow. Hope for Tomorrow is empowering women like victims of disasters, violence, human trafficking. Also, we use our company to help our own organization. My question is, apart from coffee resources or agriculture in Rwanda, what else do you think can help the Rwandans? About if there is no coffee, what about if the coffee ended? Would there be another way of this country or helping themselves using their own resources apart from being funded? Let's say now, like with the economy is low, many people are not funding. What would happen? Thank you.
Mm-hmm.
And could you pass the mic to your left? Thank you.
Actually, do you mean other income generating activities or, okay. Well, my specialty is not really economic growth. It's more health. I'm not sure, but I think, people have already been talking about trying to find other income generating activities outside of coffee, realizing that it's only you only receive revenue once a year in that brief coffee season from March to July. So some ideas that have come from our agribusiness staff were sort of small, what do you call it? Sort of beekeeping, small projects you can do at home. If it's beekeeping, if it's handicrafts, if it's chickens, sort of small livestock programs that people can do individually. But in terms of other, I don't know, I think education. I think people need to be educated in order to be able to make decisions and make their lives better and take control of their cooperatives and understand that they own them and these are resources. I think there's still this mentality of the cooperative is not for me, it's for so-and-so, the manager, or Tim Schilling, who was the director of Spread for many years. People say, oh, the coffee's for him. I mean, that people didn't really understand that they, so I think there has to be some empowerment for no matter any income generating activity that happens. So people take ownership. But in terms of specifics outside of coffee, I'm not sure. I mean, I think in certain areas they could do fruit tree production. Maracuja, the passion fruit, in certain areas has kind of been an undeveloped something to focus on around Nyungwe National Park. But yeah, that's about it.
Hi, my name is Lorette Kakuza. I'm with SEDPA, the Senior Reproductive Health Advisor there, and I was interested, it sounds like a great program, and thanks for sharing it. I was interested in getting a little bit more information around some of the reproductive health services that are available. You said clinics are available, but there's some either distance issues in accessing them, and stigma. Are they standalone HIV family planning, or are they integrated services all in one clinic is one question. And also, I was interested in your referral system. So the PHEs give the people referral slips that they take to these clinics to get the services. The clinic stamps them, and then they bring them back to the PHE for confirmation that that referral actually happened. Mm-hmm. I'm wondering is that the difference between the 1,000 people who reached services and the 347 confirmed FP users?
Yeah. So so the 347 new family planning users is just from the mobile services, because we were actually there when people were it was measured during the mobile services. The referrals, they're just grouped together. There's I believe it comes from that. But the yes, they send people to local health services, and then they come back and show that they actually made it to the clinic. In terms of the integrated services, I'm not sure about the actual service delivery, if they are given in an integrated fashion, but they occur at the same health center. So, and then you have issues with Catholic health centers that may not provide family planning, and they'll refer to a health post that could be nearby, but that's also, there's limitations there because they may not be open every day of the week, and so it does provide some more access, some barriers. Yeah.
We go to the side of the room, and if it's okay, we'll capture 2 or 3 questions. Yeah.
Sure. Oh, okay. Sure.
And then answer them.
Thank you very much, and thank you very much for telling the story. It was quite impressive what you have been able to accomplish in just 2 years. My question, I have actually 2 related questions. One is the communities that you worked with, they had different income generating activities. Coffee was certainly a very strong one. Pyrethrum was another one, and you also spoke briefly about the Le Parc de Volcan and the mountain gorillas. And how would you describe the differences between the PHE approach depending on what the income source was? Or was it very similar across? But I could imagine it may not have been, especially when you talk about wildlife sanctuaries versus cash crop. The related question was about the role of the private sector. You mentioned there was some funding from the GDA initially, and was there any contribution by the private sector, and what role may they play in the long run in terms of sustaining these activities? Would there be interest, for example, by the private sector to pay for some of these programs, which are now paid for by USAID? Thanks.
And can we get the mic to Justine in the back?
I don't think I said my name right. Eckart Kleinau,
Thank you.
RTI International.
Thank you.
Hi, my name is Justine Lindemann. I work for the Africa program here at the Woodrow Wilson Center. I have a question about different methods of outreach and communication, especially when it comes to information sharing. I know that in agribusiness, cell phones have been extremely useful as far as sharing market prices and, methods of getting produce and products to different regional markets. And I'm wondering if you've been able to use this at all. I mean, you mentioned radio programs that have been in use. I'm wondering if have been able to use like SMSing or any sort of cell phone technology when it comes to health information sharing and, giving people information about where clinics are, when the mobile units are going to be open, how they can access testing services and stuff like that. Thank you.
Yes.
I'll start with that one. No, we haven't been doing anything with mobile phones. It's a very small program. We have 2 people in the south, and then we just recruited 2 people this year for the northern pyrethrum. So it's a very low tech program. I have heard about PSI doing that, I think, in Congo, where there's areas of no infrastructure. It's really difficult to share information. The distances are really great. I have heard that that's happening. In Rwanda, I'm not sure if people are, I'm not really certain. It's not been a focus of spread either in their agribusiness work. It probably informally happens, communication that way, but it's not a formal project. But it seems like an interesting idea. We tended to work strictly through the extension agents for outreach and communication primarily, but most people do have cell phones, so it helps for coordinating meetings and doing coordinating supervision and outreach, and it definitely makes things much easier, but it's not a specific part of the program. In terms of the PHE approach, whether it's different with different agribusiness activities, I believe yes. With spread, we've tended to, again, low resources, so we've taken the lessons learned from the coffee and pretty much applied them to the pyrethrum. So it's the same idea of trying to train peer educators and extension agents to raise awareness. There has been something a bit different. Youth reproductive health was deemed a big priority around the Volcanoes National Park. They have the highest fertility rates in the country, highest population density, a lot of youth with no work, no land to farm. And the Volcanoes National Park, it blocks off a certain portion of arable land. So that was a priority. So we've worked with health centers to kind of rectify that need and improve their abilities to provide reproductive health services specifically for youth and things like that. And in terms of mobile services, it's been a bit different because with coffee, the harvest happens 3 months out of the year. It's predictable. It's farmers group to come bring their cherries to the washing station or to coffee purchase points. With pyrethrum, the harvest activities. So it was easy to find them, basically, during that those activities, those agribusiness activities. But with pyrethrum, the harvest lasts 6 months, and it's every 2 weeks. Farmers are picking flowers and taking it somewhere. And it's actually... it's hard to reach them at a specific location. So the mobile service activities have been a little bit different. It's been more trying to meet them, not necessarily during harvest, but just make sure we dedicate some time and find them in their communities. We don't actually do anything related to conservation with spread. It's more agribusiness. So, aside from the fact that we work with communities that live around Volcanoes National Park, we actually don't work on those park human interactions like a lot of other PHE programs, just to clarify. And for the GDA, the 2 GDAs, for chili pepper, it's with USAID and a Dutch chili pepper importing company, Troboka, I think they're called. And for pyrethrum, it's USAID and SC Johnson, actually, in the U.S., because they're a primary buyer of pyrethrum for natural insecticides. So it was in their interest to really help develop this sector. And in both of these cases, they're not really contributing much for health just yet, but SC Johnson has expressed interest. So we were trying to put together a small grant proposal for them to address these water and sanitation issues that we couldn't address with USAID funds. But again, it's a slow process. We have very little staff, and we're in the field a lot. But I think there's a huge possibility because you don't have those restrictions on funding. You have money, and with these private companies, and if they deem it, important, they'll fund it. So I think it's really exciting. Yeah, I know SC Johnson does a lot of those public-private partnerships in East Africa. So
great. We'll go in the front here.
That is your phone. You mentioned that it was somewhere in your bag. She couldn't find it earlier and said she didn't have it with her.
It's a very uplifting ring.
The phone is found.
Sorry.
I'm glad I turned off my cell phone. My name is Ray Edelman. I'm a pediatrician, and I've spent some time in Africa. And I know there are a lot of gender and societal issues that make population control very, very difficult. And I had two questions. One is, what were the kinds of family planning services that were actually made available? And two, did you find within local areas that there were certain, if you will, influential power brokers that you could approach that might be able to get the message out to the community?
Mm-hmm.
Can you pass the mic over? Thank you.
Hello, I'm Devjit Sen from the White Ribbon Alliance for Safe Motherhood, and I had two related questions. So you mentioned that you had reached out to 120,000 people vis-a-vis HIV/AIDS messaging, 90,000 for family planning, 40,000 for maternal and child health. However, on that page, you also mentioned that the number of people who had undergone HIV testing, the number of condoms that had been sold were considerably lower. They were in like the lower single-digit thousands. So I was wondering if you sort of measured the impact of your interventions vis-a-vis, for instance, not just like looking at statistics, but sort of looking at people's change of their behaviors vis-a-vis, say, concurrent relationships, which many scientists and researchers propose as a main driver of the epidemic in sub-Saharan Africa. So I was just wondering if you also did kind of like focus groups, one-on-one interviews to see if there was a change of behavior which could not be measured, like, say, with the number of tests, the number of condoms sold, etc. And in my related question, you also did mention about the Rwandan community insurance scheme, the Mutualis, and I was wondering what the penetration of the Mutualis is and whether you could, and if it is something very impressive, if you could maybe use some of the lessons learned, some of the best practices from Mutualis, or even talk of like a direct sort of tie-up with them in some way or the other to reach out to more people more efficiently. So these are my two questions. Thanks.
In terms of the Mutual, I'm not an expert in the numbers, but I believe it's quite high. I think coverage is upwards of 90% or something. It depends on the sector. It actually could be closer to 80 or something, depending. But it's high, I think. Maybe 90 is too high, maybe 80. But I think and it's been huge and instrumental in increasing uptake of health services. I know that. And it's quite cheap. It's about $2 a year per person. So in terms of best practices, I'm not involved much with health financing, but I think I've heard that sustainability is a huge issue because the money comes from Global Fund and that's going to run out eventually. And so there's been some issues on how it's going to be sustained. But in the numbers in terms of people we've reached, the majority of our activities are more health education and sort of interpersonal communication. As I said, we try to work on the behavior change through these outreach workers. And the VCT, the numbers for the voluntary counseling and testing, those are from just brief activities we'll do during coffee season. So I think that's why the numbers are quite low. And it's not measuring people that go on their own to these services. Apparently the referrals have gone down too over time because anecdotally, the peer educators say that people no longer need the referrals. They'll go on their own. They don't need to have the slip to go. So I think there's a lot that we're not measuring. Like I said, our M&E is a challenge at a small project. So also to answer your question about looking at behavior change for concurrent partnerships. We did some focus groups and interviews, but they were more stakeholder group interviews with program staff, district officials, partners. And then just to get, again, for time and resource constraints, we did focus groups with men and women and groups of health center staff, sector officials, and peer educators. So we couldn't really address these personal, sexual relationship issues. But there's been a lot of, at least talk that there has been a perceived impact in the way people are thinking about protecting themselves from HIV and things, but it's difficult. We didn't do a behavioral survey. Yeah. And for your question about contraceptive methods, pretty much everything is available aside from vasectomy and the permanent methods. And there's one hospital in the north that's offering vasectomy, and he's starting to train other people in the country. But in general, you can find condoms for free at health centers. Everything's covered with the mutuelle. All family planning methods are covered. So Depo-Provera, Jadel, the implants, and people prefer the injections, I think, in general. That's the preferred method. And there's pills. People don't really prefer the pills too much. So you can get a range of family planning methods. Mm-hmm.
Could I just add on to that? I think one of the challenges of these projects has been to get the actual commodities out to the rural areas, because injectables are the most popular method in almost all of these project areas, and those aren't necessarily available unless the right partners are involved and are actively involved in training community health workers in provision of depot. So if somebody does, you might be able to give out condoms through a relationship with PSI, but certainly didn't have the ability to train the animateurs in depot. Mm-hmm. And that, I think, has been a challenge for some of these projects.
It's actually been, the government just approved community-based distribution of injectables, so that should be coming out soon. That should be happening soon. And in terms of your question for the power brokers in the community, did you just mean people who could sort of help pass the convince?
Influential people
yeah.
could influence others in their behavior.
Yeah.
My very limited experience, they're all often identified in a given region.
Mm-hmm.
Certain well-respected influential people that can.
Yeah. Well, I think, we use the peer educator approach in terms of getting further down into those communities and knowing specific people. I'm not sure. But I think people giving testimonies and farmers speaking to farmers, I think that's powerful. And again, in Rwanda, the government is a very strong supporter of family planning. So people listen to the government in Rwanda. And so, they listen to the radio, they're getting it from all sides, from sector level officials, they're getting this pro-family planning message. And so I think that's been very instrumental in helping people, choose, because they see it as a government priority. They say we have to develop our country. There's still a lot of, myths and everything that requires that interpersonal communication. But in general, there's huge support from the government, and yeah, I think that helps.
Right in the back, and then we go to Heather.
I'm Sujata Rana from CHF International, and my question goes back to the co-ops that you work with. And I was just curious, were these co-ops already working in these areas? Were they sort of pre-formed? Because we have a program in Rwanda, and we're working with a lot of co-ops. But what we ended up doing is working with co-op associations of people living with HIV/AIDS, which, according to Rwandan law, then had to become cooperatives. So the challenge has been trying to get these groups of people whose only sort of commonality is the fact that they were probably in a support group of people living with HIV/AIDS, and trying to get them engaged in an economically productive activity. And I was just curious about how spread worked with your co-ops, whether you have, any numbers of people living with HIV/AIDS in these groups and so on.
We're going to take one more. Heather, right across thank you.
Thank you. Hi, I'm Heather Diagnos. I'm the Population Health Environment Technical Advisor at USAID's Office of Population and Reproductive Health. And I have two questions, but before I ask them, I just want to say that I've been involved with this project from the inception, and I want to congratulate Irene, because it really was not a great project. It was not integrated, and the health piece was very weak when it started, and it's really been due to Irene's work that it is such a fabulous example of an integrated project. So thank you and congratulations. And my two questions are, the first is, since I'm within USAID, I'm very interested in your point that it's so difficult to get the different funding streams to work together. And you had, it sounds like, 4 different flavors of money. And I'd be interested in knowing any recommendations that you have for us at USAID who are trying to promote this in terms of what could we do better. My second question is, it seems like the real strength of this project is the type of integrated messages that were provided, that was where the behavior change really occurred. And you had spoken a bit about the one message, which was people having more money from coffee production, which meant potentially spending it on negative things like alcohol or positive things like family planning. So I'd like to know how did those messages, who developed them, or how did you get them? Because often the hardest things about these projects is developing those messages.
Okay. First of all, I want to thank you, Heather, because you actually were the one that had the ideas for the integrated project. So I feel like I kind of came with a roadmap. So yeah, I can't take all the credit. But in terms of recommendations for USAID, I may need to think about this and talk to you later, because I think it's challenging. I mean, I think you have to have the mission support at least to do that, and I think that's been challenging. I don't think in Rwanda currently there's a lot of support for these smaller wraparound projects. People are going more for the larger hundreds of millions of dollars of projects. So I think you have to have that support first of all, and I think the rest you can sort of make it happen. I mean, unless they're new integrated funding streams that are developed, or that are just more kind of a holistic, you know, that they're a little more flexible. The indicators are not already set out from the get-go. But I still think at least maybe supporting it from the inception phase of the project could be useful. You know, supporting program managers to think in an integrated fashion, even if their funding comes from separate, you know, vertical programs, maybe encouraging them to, when they're scoping out their work plans, to really think about how they can build on each other's strengths. And maybe promoting more evaluation and sharing the lessons learned, you know, putting some money into thinking about because as a small project, we were really unable to do a solid impact evaluation. It's too early, it's too resource intensive. So, but, you know, donors with money like that could potentially really help build that evidence base and maybe promote changes later. In terms of the integrated messages, I think they just come from the community. I think they know, you know, they live there, they know, they see the difference. They say, oh, now that I have less kids, I have money to save. I can do other things. I can participate in coffee. I used to never be able to because I was giving birth every year. Those things, I mean, people, I think it's not rocket science. I think they understand. And I think maybe sitting here and trying to come up with them is challenging, but I think in the field, people see it. And I think the types of integrated messages were sort of the impact on the family revenue, the family size, the impact on coffee activities. Now, people said now we have time, we have more time to, or at least they appreciated, you know, that in theory you would have more time and more energy to spend on coffee and agribusiness and other income-generating activities. And you know, just having the agribusiness staff talk about how you can have a farmer who has a good amount of money but doesn't realize that it only costs a little bit to, you know, to buy malaria medicine. So I think giving those examples, and people see it all the time. There was another one up that I didn't put up there that another cooperative manager said that you'll have a coffee farmer make, you know, 100,000 francs in one season, like $200, and sit and drink for a month and then come and ask the cooperative for a loan. So people realize that there has to be a lot of that behavior change, and the capacity building and the empowerment and education has to go along with that income generating activity. Otherwise, it's not beneficial. So I think you just learn it by being there and seeing what's happening. And okay, so, and the cooperatives, yeah, were they preformed? They, yes, the ones that the health program has focused on were already preformed. There's 2 cooperatives and 1 private female-owned enterprise. So, but there's different qualities to the cooperatives. Some of them were sort of enforced by the government back in I think the 1990s when there was this push to put people into cooperatives, especially for coffee. And agribusiness staff that work on co-op development and coffee, they all say, you know, there's one cooperative, Maraba, that is sort of an ideal cooperative because it really came from the people. They wanted to do it and they wanted to form it. And so they function pretty well. They've paid off their short-term loans. They're paying the health insurance for their member farmers. They're fair trade certified. They have good relations. They're just more successful. They're a strong cooperative. They have a strong extension system. Whereas you have others that are sort of, they're likely to fall apart. You know, every year you never know if they're going to make it, and these guys tend to be the ones that were more enforced from the outside. So, you know, yes, generally we work with the ones that were already formed because that happened back in the Pearl days. But we also had one cooperative we had to stop working with because they dissolved. We may try to start up with them again because it was difficult for health. They were very motivated and working really well, but because their cooperative dissolved and their agribusiness relationship was spread and Rashosko, the umbrella company, dissolved, we were forced to stop, which is a difficult thing. But I have heard about that in Rwanda with CHAMP and how it's challenging getting people to change their whole purpose from being an association for social support to now being a business trying to make money. I think I've heard that's very challenging, and I'm not sure. I think it's difficult. I know Land O'Lakes in Rwanda is also working with associations of people living with HIV and trying to help them with dairy development. And I think it's tricky. People have a different idea of why they're coming together, if it's for social support and health services or if it's for, you know, a business. So, yeah, I don't know.
Sean, can I just add
Sure,
one little
sure.
comment there? I think Irene's point about the challenges of an evaluation for this project, more generally putting this in context, are true for many of these projects. And, you know, we're trying to capture the best practices, but it's interesting to note that most of these projects have never visited one another and don't, even though they're close to one another. WWF has done a good job of getting some of their field staff from one project to another and learning how they do evaluation. But, you know, I think we maybe failed Irene in getting her to a project where she could have seen in the beginning how to do that evaluation. And it is our fault.
I like that.
But this is something that I think that several of us are working on addressing, and both the best, sharing the best practices, visiting one another's projects, and building an evidence base. So hopefully you can stay tuned for more on that.
Hi, my name is Genevieve Leopold, and I'm a graduate student. In one day, I'll be done with my first year of graduate school at George Washington in global public health, specifying in design, monitoring, and evaluation. And thank you again for coming today. I really appreciate this message of sort of the that it's not just inputs that is going to improve health outcomes, but that it is the system strengthening and capacity building and everything in between that has to happen. And particularly, to get to my question, this summer I'll be doing an independent study where a team of us are actually doing a systematic literature review of where the influence of health education programs with an income generation component, how that influences reproductive health outcomes. And this was exactly, a model of that. Particularly, and then at the end of the summer, we'll be doing field work in Guatemala with a women's non-government organization called FACIRGUA in the West. And they have an existing, they're already working with, they already have income generation activities. My question is that this term, the coffee extension agents, it sounds like their sort of role is coffee extension agents. They were already established coffee growers, coffee farmers with their expertise in sort of the income generation component. What did that sort of empowerment look like to change their role, or I guess maybe build on their existing role of coffee farmers to take on this new empowerment and responsibility of also community health educators? Sort of what did that initial sort of meeting look like, and kind of how did you create demand for that? And then secondly, did you see, this is kind of piggybacking on a question in the back, but were there certain business models? It sounds like the cooperative has been something that the cooperative model of economic activity or income generation has been kind of the predominant model in your group, but have you seen this sort of situation working in for-profit, non-profit? Are there different sort of models other than the cooperative that you have seen that have worked, or is that
doing
sort of
health and agribusiness?
Yeah, health and agribusiness, or is it just kind of in your experience, has it been the cooperative that's been best? Obviously, this would depend on the country and community and everything, but yeah, those are my main two questions.
I don't know anybody else doing health and agribusiness per se, in Rwanda anyway. Like I said, Land O'Lakes is doing a bit with, they promote the dairy sector, and I know they receive some PEPFAR funds, but they're working with associations of people living with HIV to sort of help them with the income generation piece and the agribusiness piece. So they don't really do anything with health. It's kind of, they're just sort of working with these groups of people. So yeah, I'm not sure of other people. I know that I think this has sparked some interest in Rwanda in terms of there's large tea cooperatives as well, and district officials have said, well, this has worked. We like this approach. We'd like to see about doing it with tea, or other people that come into the district and would like to work with agribusiness. They would like to. There's been talk that they would like to suggest integrating health as well. But it's pretty unique within Rwanda. I'm not sure. It's probably happening in other countries, but in this case, no. I mean, fair trade has occupational health standards, and so I know that happens in terms of first aid and things like that. And so fair trade certified cooperatives or businesses have to also incorporate those types of standards. But in terms of the HIV prevention and the sort of, I don't know, the more reproductive health outreach on a consistent basis this way, really integrating a technically sound health approach, I haven't really heard of it, but it very well could be happening. And the animateurs were really excited to be health educators. We approached them and we asked them to help us do sort of a survey and talk to their farmers in their grower zone and talk to them about their health needs as sort of a first step. And I mean, they were enthusiastic about that and everything after. I think people are really knowledge hungry and they love to learn. And I'm not sure if you train them on something else, if they would be just as excited, or if it's because they see the value on their own lives. But they've been great. They've been really great. They're primarily men. That's why we wanted to also have the peer educators, youth and adults, half and half, men and women, because the animateurs, a lot of them are older men. Like they're selected as coffee extension agents because they're good coffee farmers, which doesn't necessarily make them model, for health. I mean, they're often, we'll see them drinking a beer before the meeting, and you're like, oh, you're the community, you're the example, So the peer educators, we were trying to get people to be selected by their communities because they were, they had those qualities of being a good peer educator for health and behavior change. So, but yeah, they were enthusiastic. And I mean, several times in the evaluation, it came out that it's easy. It's possible to do both. It's easy to do both. And in fact, it's very easy to do both. I mean, sometimes people worry that maybe you're overburdening them, but no, I don't think so. And it's information they use in their own lives. There's been, I think, a bigger impact probably on the peer educators themselves because they get monthly visits with our trained health staff, and so they get sort of consistent education, and they've cleaned up a lot in terms of hygiene has improved, and they're probably the ones gaining the most out of it. So yeah, it was fairly easy in that regard.
We have a question in the back.
Actually, hi, I'm Linda Bruce. I'm the director of the Balance Project. Actually, it's not a question. I just wanted to contribute to this discussion. We just now started working with the Wildlife Conservation Society in Zambia, which is a huge cooperative of farmers groups, and they have 50,000 farmers groups, producer groups. So they've already started, but in a very small way, trying to get health education into their activities. And so the Balance Project will be getting providing more support for family planning. So we don't have any results, but I just wanted to say that this is a big. The Dale Lewis, who runs the group, is running it exactly like a business and an agribusiness. And so we will potentially have another model within a year to be able to build onto the body of experience that you have. So it's working there. If I forget your name, but if you want to talk to me later on, I'm also around the corner from where you go to school, so somehow we can hook up. Okay.
And we'll go back over here. Thank you.
Again, this is Egger Kleiner. Thank you again for all the comments, and I would like to actually I have a dissenting voice in terms of monitoring and evaluation, because it makes it sound like it's too expensive, we really can't do it. It's an argument that we hear over and over and over again, and it just doesn't have to be that way. Yes, impact evaluations can be very expensive, but we have so many examples where NGOs, for example, USAID-funded PVOs, actually use an instrument called the Knowledge, Practice and Coverage Surveys. These are relatively inexpensive. And one thought that as I was listening to the discussion was, would it not be possible to implement at least an end-of-project evaluation, for example, where you would be looking at some comparison communities where you don't have the integrated approach, where it's just government services available, and you look at the intervention communities. At least it gives you some idea what is the differential, what has changed. I mean, you are still without a baseline sort of, you are losing an important piece of information, but that can't be helped. But at least it would give you a better sense. Have these communities, in terms of behavior change, in terms of product availability, accessibility to injectable contraceptives, for example, is there a difference between those? And that probably can be done for relatively little money. And I don't know how much there is available for the last 1.5 years. But there may be a way out, and it would be too bad if such a project would end without us being able to gather more quantifiable evidence how things have worked out. That's my thought. Thanks.
Any other questions?
Can I respond to that?
Sure, please.
I said, yeah. Well, yeah. And just so I don't get doubly blamed, I actually have suggested this. I think I did suggest this in the 16-hour car ride in Ethiopia, that it was relatively inexpensive to put together a survey and train a small team to get out there and collect that information. And I think that people don't believe it until they've seen that smaller groups than them have done it and can do it. And so that's why one of the things is actually showing, here's an instrument that you could use, easily adapt, and do relatively inexpensively. And here's how to do it. Because I think that my perspective from talking to Irene about that was, she found that daunting, the task of doing that, and the cost potentially daunting. And I kept saying, no, it could be done. It can be done. So that's something that I agree with your message, and we need to spread that same message, I think, amongst the body of not just small integrated projects, but small PVOs and others, that they can evaluate their work.
Okay, in the back.
Hi, I'm Mara Russell with Land O'Lakes, and Irene, I think Carmen sent me. So anyway, so I was, unfortunately, I was kind of late for your presentation, so I apologize and hope that I can get a copy. But I will tell you, you've mentioned about Land O'Lakes doing this work with people with HIV and trying to integrate them into dairy value chain activities. In fact, we have similar funding in Ethiopia. It is only due to the fact that PEPFAR provided the wraparound funding along with EGAT that these integrated activities actually took place. And And I think we would very much welcome the opportunity to look at integrating health and nutrition and possibly even family planning type activities as well with some of our co-ops. But once again, it's the funding streams that come down. If there were an opportunity to maybe connect some of those funding streams, either through the Global Hunger and Food Security Initiative or Feed the Future, as well as the new Global Health Initiative, looking at the strategy in terms of how that implementation takes place, that might be a way to look at potential greater opportunities for integration. I mean, otherwise we wouldn't be doing it at all. Okay, we'd just be working with the dairy value chain. So, you know, that whatever serendipitous opportunity was why we even got involved in the first place. And we didn't even have a specialist in that arena. We now do. So that opens up opportunity. The other thing that I just wanted to mention is that if it could be pointed out that there are certain, what shall I say, economies of scale or cost savings that could be provided through, say, you know, one of the big areas of concern in agriculture and economic development is availability of inputs, okay? It's a supply chain, basically, similar to a supply chain for other kinds of, for the types of health inputs and contraceptives and so forth that you've been mentioning. And basically they have to get out to people who are remote. If there could be some way of looking at it in terms of this is a supply chain, a supply chain is a supply chain, is there some way of ensuring that these supplies get through the chain in a similar manner? They're all commodities. How do we, you know, that's a question maybe to raise, to look at. And then certainly you've made, you know, I'm sure, although I probably missed it, a very important point about messaging. And in fact, in the whole arena of ag productivity and improved technology and so forth, there's also an issue about messaging, which I will say that the health community is miles ahead of the agricultural community in terms of being able to use that behavior change type technology. So if we could look at these various different similarities as opposed to, oh, that's totally different and it's nothing I know about. No, they're very similar types of things. If we could look at maybe developing strategies where there, you know, obviously there are going to be differences, but there may be some similarities that we can look at in terms of both supplying commodities and conveying messages and communicating, and then look at how those joint strategies may be possible. It's difficult. It means bringing together different specializations and different technical specialists into the same room and getting them to talk to each other, which is, I know, very hard, but just a, you know, kind of an idea, and I don't know what people think of it, but, you know, when you get into the situation where you see both things happening at once, you know, you see that there may be ways to do this better.
One last question? No? Okay. Oh, okay. We one in the back, all the way. Thanks.
Hi, I'm Megan Parker. I work here at the Environmental Change and Security Program. I just had a question sort of to follow on what a number of people have said, talking about the measuring and evaluation, but particularly looking at the synergy with the agribusiness from the perspective of business productivity. A lot of the measurements that have been discussed have been talking about the success on the health side, but also what about measuring the impact of the health interventions on business productivity, as part of building a case to get more involvement from the business entities, and then also as part of a scaling up to continue the involvement of multinationals like SC Johnson or Land O'Lakes.
Question?
I wondered if you had looked at those, or if
Okay.
anybody did know of any of those kinds of indicators.
Mm-hmm. Yeah, that wasn't part. We made a decision based on the fact that, given that we only had about a year and a half of implementation, and the fact that the agribusiness M&E was sort of tricky. I think it's hard if you don't have I don't know. I think, I basically wasn't sure how to come up with these quantitative, or if it would even be possible to look at pricing, let's say. I mean, could it really impact enough that coffee prices or there would be some sort of quantitative impact on the agribusiness level? I think I don't have that technical expertise, and I wasn't really confident in the M&E that was going on in the agribusiness side. I mean, in the field, people are crazy, especially with agribusiness and coffee. I mean, it's always putting out fires. There's always something that's happening. So really getting program managers to have a solid system of monitoring and evaluation that's set up from the beginning is difficult. It's a huge challenge. And I know that it's feasible, probably, but the realities in the field are you're juggling a million things, and M&E is always the last thing, unfortunately. So we opted to do a qualitative, just exploration of people's perceptions. And we also heard that USAID would potentially be funding, because they put so much into investments into the agribusiness sector in Rwanda and coffee, that they would be sending out an impact evaluation team later. But whether or not they're going to be looking at these sort of integrated effects is unclear. Hopefully they will be looking at the health program as well. But the way things go, they could very well just be looking at the agribusiness improvements. So, but I think it's completely valid, and I think that would be really helpful to have that kind of information. Unfortunately, it was more anecdotal. It was more of just, how do people feel about it, and did they notice an impact? And yes, but you don't really know, don't have numbers necessarily associated with it.
I think it would be important also to ask, in the qualitative questions, you can ask about their sickness, how often they perceive that they've been sick, whether that has contributed to their ability to work, and whether or not there were any changes due to the program. So those are questions. I think it's a good point, and I think that those are the questions that we really do need to ask, and need to share those kinds of questions amongst these different efforts to see, because it is one of the arguments that people are healthier and therefore more able to participate in livelihood activities or conservation activities that an organization is interested in. Well, we need to measure that, at least even qualitatively. So,
and we do have qualitative information about that. Great. Yeah,
it sounds like people are interested.
Well, we have one last question, and then I think we're at our time.
Sorry, it's not so much a question, but I was just thinking it might be an idea to come up with a minimum set of indicators you would look at in terms of integrated programming. So what are the outcomes you're looking for? No, days lost to sickness. I mean, especially that would be critical if you work with any co-op in Africa, in sub-Saharan Africa, where you will probably run into people living with HIV/AIDS or what have you. So if there was even a minimum list of indicators that people could use as appropriate for their programs, I think that would be really useful.
Let me just say that it does such a list does exist, thanks to USAID's investment in the Measure evaluation project at University of North Carolina, Chapel Hill, and other partners. They produced a guide about 2 years ago, a guide of indicators for population health environment integrated programs. And so there are many indicators in there. They are almost all quantitative, survey-based, so they don't talk about qualitative questions. But the ideas ought to be thought of in terms of what kind of qualitative information to collect.
And they're also a bit more conservation and health related, not really, say, agribusiness and health.
That's true. That is true. That's a good point. And then, in addition, the Measure evaluation has produced a curriculum for training people in how to monitor and evaluate these types of projects. This was produced and is publicly available for somebody to take, to use, to train staff, monitoring and evaluation staff. It's available through Measure Evaluation and also through K4Health's PHE toolkit site. If you go to k4health.org, thank you, and look for population health environment, you will find a whole host of resources, lessons learned, best practices, training materials, the monitoring and evaluation guide, and much more. And thanks to the Balanced Project, who's been coordinating the effort to get those tools and resources available. So that's something that is available to practitioners.
If you just go on the menu, once you get on the site, there's a menu on the left-hand side, and it says PHE Toolkit. Click on that, bingo, you're there.
Well, I encourage us all to continue this conversation. I want to take this time and please join me in thanking our two speakers, Irene and Jason. Just a few notes. If you go to our website, wilsoncenter.org/ECSP, you'll find a meeting summary about this meeting in a few days. And also, we have a new column on our blog called On the Beat, and it's the newsecuritybeat.blogspot.com for stories like Irene's and a few more from folks on the ground describing what they're seeing and how to integrate and whatnot, lessons learned. So that's a good one. And definitely looking forward to that map for PRB. So I'm glad we got a glimpse of it today. So thank you for coming and enjoy the great day.